Good morning, everyone, or good afternoon, I should say. And thank you all for joining us for the December CCSP monthly call. We'll give a moment, as always, just for everyone to get connected. And so great to see everyone on in this cold day. So as you're connecting, if you could put your name and org in the chat, and for this month, what you're looking forward to in 2022, since this is our last CCSP monthly call of the year. So this whole fall has flown by super fast. So really looking forward to starting off a new year and continuing on with our next year or next half of the year for CCSP. So as everyone knows, I'm Elsa Weltzine. I'm the program manager for CCSP. And what I'm most looking forward to in 2022 is that I'm getting married in September. So I have a lot of planning to do, but getting really excited. So hi, Heather from Brenner Caritas. Great also to see so many people on from the Valleywide team. We have Ryan on from Clinica, Colorado, a couple members of our Peak Vista team I'm seeing as well, and it looks like Marillac is joining as well. So thanks everyone for joining. And again, if you could put your name and org in the chat, as well as what you're most excited for 2022. And I'm going to share my screen. All right. Can you all see those slides okay? I see a nod from Laura. Great. So today we have a big agenda, so I'm going to go ahead and get started as everyone is introducing in the chat and putting what they're most excited for 2022. We have a few different program announcements today, mid-year reminders, another reminder about some of the capacity building opportunities, an exciting policy that's in the works, as well as our upcoming events and opportunities. And then the main content focus for today is going to be around stool-based testing, as that's one of our capacity building areas, where we'll be discussing a little bit about strategies and best practices, introducing with Ryan Maccabee joining from the Clinica, Colorado team to share a little bit of what they've been doing with the FIT standing order. So Andy, anything else you want to note as we jump into our agenda?
Oh, sorry, Elsa, I was on mute. I would just remind everybody we are halfway through the year. So kudos. I think our screening numbers are on board. Elsa's probably going to be talking about that, but just really excited that we did get this 2-year extension, and just to remind us all that end of the June timeframe, and that's going to be here before we know it. So with the holidays and everything coming forward, just a reminder to hit the road running early January again, so we hit our targets and we get as many people screened and utilize all of those resources, which I know Elsa's going to be talking about as well.
Awesome. Thanks, Andy. And yes, huge kudos to all the work you all have been doing as the COVID pandemic continues on and has not let up as we had hoped by this point. So really just want to say a huge kudos for all of the work you all have been doing to continue to get patients in for those important screenings. And just wanted to shout out a couple of the things I saw in the chat. So excited that some people are going to get some skiing in 2022, and everyone just looking forward to a new year, couple trips in there. So, and thank you all for all the warm wishes for my wedding. So for our mid-year reminders, the end of the second quarter is the end of December. So a reminder as we're approaching our quarterly reporting time to please submit your November and December evaluation reports and billing invoices in a timely manner for evaluation reporting. November is due December 10th, so at the end of this week. December due January 10th. If you're expecting significant delays, please let us know, as our second quarter report is due January 15th. And we know not all invoices are always able to be submitted by those dates, but please get those submitted as soon as your billing departments can do so. And it's really important for us to have this data and the invoices so that as we do our mid-year review of use of allocations, we can have a better idea of where you all are at this point in the year of reaching your goals, which were the same as last year's goals, and how many you used at that point, so that we can see if we need more resources or if some clinics aren't able to use all of them. So please let us know if you're expecting any significant changes, but we'll be reviewing those as well. And also wanted to give a friendly reminder that we still have our barrier reduction funds available, and really hoping that clinics will use all of this pot of money up this year to help patients with bowel prep, transportation. So that includes, bus vouchers, if they're taking taxis, those types of things, for homeless or unhoused patients, hotel costs, or if they have a really long drive to do the prep. And then childcare, elder care, all of those things are eligible. And there might be some other things that are applicable as well. So please submit your requests and invoices to us so we can get those approved and get you reimbursed for helping patients with those services. We can't, as always, we can't reimburse the patients directly, but we can reimburse your clinic if you give those funds and resources out to your patients. So those funds really are still available and really are available for you all to help your patients. So please submit those requests to us. And if you've submitted a request and we haven't gotten back to you, please send us a nudge as well, but I don't think we've missed any. And then big reminder about our capacity building opportunities that are new this year. So as you know, we've discussed these opportunities with each of you, that stool-based testing, lung cancer screening, and family history risk assessment are the focus areas for these. And we really would like to help meet you where you're at to help build capacity, improve processes, or start with some of the initial foundation building for one or more of those areas, if that's something you're already doing work in or are interested in looking at what it could look like to start to move towards implementation. So there's just a short form needed to launch this, which is what you think you would focus on, what a goal would be, and then a short capacity assessment of where you're at right now. And based on your goal, we'd help figure out a couple of evaluation metrics, less than 5, that you would report on. So definitely much smaller scale than the level of detail required for the implementation of the CRC navigation into colonoscopy. But as we're approaching this mid-year and we have one bucket of money for this available through the end of this fiscal year, and then additional opportunities available next year as well, we need to know if clinics are interested in participating this year with the startup of this process by mid-January, and hoping to onboard clinics for this year no later than March. But we'll be following up with each clinic individually based on our previous conversations to see if that's something you're still interested in. I'll resend out those interest forms as well. But this is a really good time as we're approaching the holidays to revisit these ideas that came up in our calls with your teams and see if this is something that might be feasible to start in this third quarter. And again, it can be really small scale for this year. And if you're interested in more than one opportunity, you could start with one and build upon into the next year of more than one as well. So that's where we're at with that, and happy to set up any follow-up meetings to discuss ideas. We'll also be reaching out to those that said they may be interested in participating in the research opportunity with Exact Sciences. That will provide resources for implementing a decision aid or navigation approaches for implementation of Cologuard as a stool-based testing strategy. So as we're trying to get a sense to bring to Exact Sciences of who might be interested, there's a little bit of information gathering we're trying to do. So for those who said they might be interested, we'll be sending a follow-up email as well as a survey with just a couple of pieces that will be helpful to know as we're designing this study. So Andy, I'm gonna pause there and see if you have anything else you'd like to add around that.
Sure, Elsa. So everybody, here's the thing. If you are working with CCHN on any quality initiatives around stool-based screening, if you're interested in your providers knowing about lung cancer screening, if you're interested in doing an outreach and capacity building around awareness around colorectal screening and stool-based testing, if you haven't been able to utilize genetic counseling resources, where you have that available through Ambry Genetics and through the genetic and hereditary work, there is something for everyone. So even if it's like, hey, we really want to ramp up and talk about stool-based screening, we'd like to do an outreach or awareness campaign. We know it's going to cost about $1,000 to work with the radio station, and we know it's going to be an additional $500 worth of materials. That's cool. I mean, that's fine. If you want to say, hey, we're working on our workflows for part of our UDS workflow, our QI work with the Rural Health Center or CCHN, and we need a little extra help, that's cool. If you want to learn more about the genetics and Ambry tool that's available and how that can implement, that's something that the program can provide free of charge. So there's big things, there's little things. I mean, we're building this in based on the response, I think, from folks about really needing some of these additional resources. Like Elsa said, if we don't know this year soon about what you need, we will probably have to, divert those funds to other areas. So the sooner that you let us know, but if you have ideas or there's even something outside of the box, just give us a phone call, and I'm guessing we can find a way to help support you. So nothing too big, nothing too little. I'm just going to be honest. I really think that the reporting side for CCSP for the navigation and colorectal work, it's something that we've tried to talk to CCPD and our funder about backing off. But in this capacity work, it's pretty low lift around the evaluation metrics. There are some things we do obviously have to count, but a lot of the work you're going to be doing in this work is for evidence-based interventions, things that we already know. So let's just get those counts and numbers, but utilize those dollars. So if you have an idea for March, if you have an idea about, your providers knowing or learning more about hereditary lung stool-based testing, just give us a jingle, ask for those dollars, and I'm sure that we can support you. So nothing too big, nothing too small.
Thanks, Andy. And yes, feel free to either shoot me an email or give me a call if you're in the early idea stage of thinking about ideas and just want to bounce a couple things off and see if that's applicable. Definitely just start the conversations, and that's a great place for us to begin the foundation. So the next thing we have to share is about a policy, a bill that's in the works that will run in the early part of the 2022 legislative session from the Colorado Cancer Coalition, leading out with support from all of the stakeholders. And it's building off of House Bill 1103 that was running in the 2020 session right as COVID hit. And so that unfortunately did not move forward. And that bill had about having colorectal cancer screenings covered for those 45 and older, as well as eliminating out-of-pocket costs for follow-up colonoscopies, since the USPSTF did lower the screening guidelines to starting at age 45. Did not have to include that part in the bill this time around, but this next iteration of the bill is really just focused on eliminating that cost sharing component for follow-up colonoscopies following positive results from non-invasive tests. It is focusing first on those that are privately insured for proof of practice, and similar legislation has been passed in other states. And the initial data is showing that this type of legislation is really helpful for reducing those healthcare costs for patients, improving early diagnosis and treatment, which is really what we're trying to do with the work in this program as well, is really trying to help reduce those barriers for patients to get screening. So as a foundation, this would really help open up those opportunities. We know this doesn't directly affect those right now who are uninsured or with public insurance. However, it really would help build that foundation and start to move towards this type of coverage for all patients. So the bill has bipartisan sponsors and is expected to run in January 2022. So it's one of the earliest bills, which will help get a lot of attention out the gate. But as this is approaching soon, the Colorado Cancer Coalition is really looking for input on the bill and personal stories from those patients and community members who have been affected by receiving out-of-pocket costs for those follow-up colonoscopies, and trying to spread the word so that the legislators hear about how important this is. So personal stories are needed from all across the state, but for some of those committee members who are in specific districts, all of the metro areas of the Front Range, the San Luis and Arkansas valleys, the Grand Junction area, those are some of the areas in particular where those personal stories can really be impactful. We did just hear that a bill draft is now available, and so that's being reviewed. And once it's ready to go, we'll share the formal bill draft with all of you within the next week. But there's so much you can do to spread the word about this. So letting us know also if your organization would be willing to provide testimony, or any of you individually share logos about why this is important, and help spread the word with all of your networks as well. That would all be super helpful. So again, Andy, if there's anything else to add on this, or if anyone has any questions, I'm going to stop here for a moment.
Elsa, can you actually bring up the list of where we particularly need? Because I think one of the things I'm thinking, everyone, and I think it's the level of comfort your medical team, your providers are, but we really could even have all of you as navigators, if you're willing to reach out to the people who are part of your district, who are the legislature in these certain areas. So whether it's on behalf of your organization, your clinic, or you as an individual navigator, if you know patients who have been really impacted by out-of-pocket costs for follow-up, which I know many of the patients we work with are Medicaid or insured, and this might not impact as much. But I think there's a lot of people, even with insurance, who end up with strong out-of-pocket cost and cost sharing that can be upwards of anywhere from a couple hundred to several $1,000s. So these are the areas, and I think there's areas where we really do need advocates, patient navigators, clinicians, to contact their sponsors in this area to talk about this bill and why it's needed. We know that right now, even if a stool-based test is positive, that follow-up is absolutely part of the preventive screening, but it's oftentimes coded diagnostic, and that's really the issue. But it's one of the biggest reasons for failure for follow-up and then people having late-stage disease. So you can see there's some names there. We're getting those emails, those contacts, but it's really going to take everyone through our Cancer Coalition, who our CCSP program, and others to be able to change this so the insurances do right for the coverage that they do provide. People pay a lot of money for insurance. And so for them to deny a follow-up colonoscopy when there very well could be something wrong is actually just unethical. The governor has been very interesting about this proposal. Essentially, we ran the same bill in 2020. He noted that this is considered a health mandate, and he will not allow any more health mandates that will drive up insurance costs. We have done our best to explain that follow-up colonoscopy will actually decrease cost because it's actually not having late-stage disease that causes more for treatment. And we're talking about improved quality of life. and actually mortality reduction. But he's actually been very interesting about this. So we need as much support as possible. We're also considering other ways for colonoscopy follow-up for people who are uninsured, building in that capacity. But this legislative cycle, we have this opportunity. We've tried to run this bill before. We have more support than we have, but we really need everyone around the table. So we'll be sending out information. If you know people who are willing to contact people in their district, if your providers are okay with that, if you want to do it as an individual volunteer, those are completely fine as well. But I am bound and determined this year that we are going to pass this. We had received support through the coalition to support this at the same time when 5 other states received that funding. Those 5 states have actually been able to pass this bill, and in Colorado, we have not. So guess what? Colorado doesn't lose, we win. So this time we need everybody really around that table. We need to have this testimony and really this support of this bill moving forward. So as much as you guys can help us, you guys are the ones in the field. And I think you are the ones in the community who can talk to your district representatives about the need for really decreasing barrier reduction. One of many things that we're going to be working on, but I think we really need to win this round.
Thanks, Andy. And yes, as the university, we're really helping provide a lot of the data around this, showing the value, why it's important, how many people are diagnosed at a late stage already in Colorado, which is about 60% of people across the state when they get a CRC diagnosis across the whole state. That's 60% are diagnosed at late stage. That's too many. And in certain areas of the state, that's even higher. So really need to have some things in place that can help divert that. Because as you all know, sometimes getting those follow-up colonoscopies are really difficult. And stool-based testing is a really great strategy to help get more screening out to people, but really need to be able to help people get those follow-up colonoscopies when they need them. So if you have any questions, please let us know, or ideas, and we'll be sharing along more information as well. So I'm bringing back up my slides. 1 second. Okay. So also, wanted to let you all know of the dates of the upcoming opportunities and events from both CCSP as well as our partners. There's a lot of great resources specifically around navigation and sustainability, as well as the screening work that we all try to provide to you. So the National Navigation Roundtable, which Andy is on their executive leadership, is having their free virtual annual meeting this Thursday from 10:30 to 1. A lot of great opportunity to network with navigators from across the nation. And so they're really going to be focusing on how we drive sustainability for the navigator role. So they'll be talking a little bit about the 5-year aim for the NNRT, as well as how we reach that aim and opportunities to network with those other navigators. So it's a really great opportunity to hear a little bit about what's happening in the navigation field beyond just Colorado, and then building off upon that to continue our sustainability work and showing the value of sustainability for navigation. We're hosting a sustainability planning webinar series with WashU in St. Louis, who really developed that initial tool and framework that we adapted for the CCSP PNSAT that you all have taken over the last year. So it's just a great level setting opportunity for a reminder of how these frameworks really can help support programs and practices such as patient navigation. And we're trying to get some additional input, as well as trying to remind some of our wider partners about this value and why it's so important. So we hope that you'll join us for this series if you're able to. The first part will be on Monday, December 13th, focused on those sustainability frameworks and tools. It's a great reminder series for anyone who might have joined your team after we started the sustainability planning component, as well as thinking about how we can continue to use these tools. We were really lucky to get this extended funding for CCSP, but this reaching towards sustainability is really important. So part 2, we'll be thinking a little bit about what's already been done, all the work that we did with all of you for using the sustainability planning tool, as well as where we go from here, because we know that even going through this process, while it's really helped with the foundation and building towards that increased capacity, we're still not there yet, and there's still more work to be done. And then also the PMTCs hosting a workshop around understanding microaggressions, specifically geared towards navigators. And then in January, instead of having our regular monthly call, the first Tuesday of January, we have canceled that call, and instead CCSP will be invited to join the Regional Health Connector monthly call that's happening on January 20th. So building upon that earlier opportunity last year, really having the opportunity to meet all of the regional health connectors in Colorado that are located in every region of the state, as well as sharing with them about what the work we do with CCSP, and then some opportunities for networking directly with them. So we hope you'll join us for that. And if anyone wasn't able to join the first opportunity, as well as those who are already able to meet some of the regional health connectors, it's a great opportunity to meet all of them this time. And then finally, bowel preparation as one of those most requested training topics for this year. We're thrilled to be hosting one of the gastroenterologists from CU for our bowel prep tips and tricks webinar for this year on February 17th. So I'm going to look at the chat and make sure I didn't miss any questions. Okay. So if you have, I'll be sending out all these links again, and they'll be also attached in the slide, but please register for these events and let me know if you have any questions or if there's other opportunities that you're hoping to see in our programming in the second half of the year that we haven't yet gotten to. So,
Elsa, I just received a note this morning that the National Navigation Roundtable hit full capacity. So okay. Unfortunately, that's not something that's open anymore. And I'm sorry, I should have corrected that earlier. Having that said, there will be communications about resources and tools that will be available that we can send along. And I do know, and I'd kind of like to share some information that right now in Colorado and nationally, there's thoughts and discussion about actually looking at policy related to reimbursement for navigation. So that's one of the areas that they're going to be covering as well. So we can be sharing more information like we are for the policy related to colorectal screening, but how do you help support that reimbursement so we can sustain the roles of navigators, not just through grant and foundation dollars, but that's one of the areas going to come forward as well. I do want to just say, Laura, always wise, Laura. Laura noted that I'm asking people if you had time or could help just by sending support for the bill to a district member, share testimony, whatever it might be. And Laura, I didn't mention this. You noted that in the past you'd received template letters. Could we do that? Yes, and I failed to mention that. We could definitely send you information to share form bill, form language that you could adapt. We would also send you the name of that representative and their email address as well. So you would get all that information if that's something. So Laura, thank you for bringing that up.
So for that initial step, if you're in one of those areas we noted where they need direct support for those districts, please let us know if this is something you're interested in as the first step, and then we'll be providing all of those resources to help you reach out to your legislators in those areas. So thank you so much, Laura, for bringing up some of those exact steps that people can take and how they can be informed with reaching out to their legislators. So without further ado, those are all the announcements we had for today. And I'm really excited that Ryan was able to join us today to share a little bit about the work they've been doing around stool-based testing at Clinica Colorado. So I'm going to turn it over to Ryan to talk a little bit about their FIT standing order. And Ryan, would you like me to share my screen with that FIT order, or is that something you wanted to drive?
I have some slides, so I will go ahead and
Okay.
share those.
Great.
All right, good afternoon, everybody. Can everybody see my slides?
Yes.
Be good. All right, good afternoon. I'm Ryan Mockabee. I am the Director of Programs at Clinica Colorado. We are a single site safety net clinic who provide primary care services for the uninsured. So we're not affiliated with Clinica Family Health. We're a single site clinic, safety net, and we do care, primary care services. And so I'll be talking about standing orders for FIT tests. This also applies to all stool-based testing kinds of things that'll be going on. Today I'll talk about what are standing orders, how we designed our standing orders, the example that we have and that we use in our clinic for FIT testing, and then some of the successes and challenges that we've experienced on this journey. So first, what are standing orders? These are part of a team-based care model. We are recipients of the Advancing Team-Based Care grant from the Colorado Health Foundation. That's been super helpful. We have a coach from John Snow International, the consultancy group that helped us with this. But standing orders essentially allow people who aren't providers to order and administer things like the FIT test without the physician or mid-level provider having to order them. So it really increases efficiency and speed in the clinic. And some of the keys to this are getting the approval from your medical director or somebody in that role, training all of your staff on how to do this, and then maintaining the momentum of making sure people are trained on this, they're doing it, and they know the steps they need to take to get it done. So to design a standing order, one of the most important things, the key really, is to assemble a cross-functional team. It can't be a medical director saying, this is how we're going to do it. You have to have front desk, medical assistants, mid-levels, management involved that brings perspectives from all levels, because the clinic works as a whole. So those perspectives are really important to noticing, oh, this little detail is needed. And I'll show some of those in our example. And then you're going to want to identify something that has a low level of medical decision-making, like a FIT test. There's not a lot of contraindications. There's not a lot of risks to having staff besides providers order these. And so a FIT test is a good opportunity for standing orders. And then in your policy, you're going to want to specify who's eligible, when the standing orders apply, when they don't apply. So you're going to want here's when you do it, and here's when you don't do it. And then in addition to an overall policy, you're going to want distinct steps that allow the staff to follow. A broad policy is good for general understanding, but direct steps are really important to training and implementing this type of thing. Receiving written approval from clinical leadership, that's like a legal step just to have in your standing order, just so it's been approved by leadership. There's no clinical contraindication or making sure you're following best practices. And the last step is teaching the standing order to all staff. And so that goes beyond just passing out a memo and saying, here's our new standing order, do this. You're going to want to demonstrate how to do it. You're going to want to watch them do it. And then make sure that if there's any questions, that you update the standing order, make sure that it's actually working as you intended. So teaching it to all staff is really important to the standing order. Okay. And then our example of a standing order, I think Elsa is going to send this out in a Word doc format. But also, if you Google standing orders FIT test, we sort of compiled this from a bunch of different resources, saw how other people did it, and compiled it into what worked best for our clinic. But yeah, there's a lot of resources out there for standing orders. This is just what ours looks like. So first, we have a purpose up top that shows everybody why we're doing this. We want to increase access to the FIT test. We have our eligibility, who's eligible, the age range, when they should be done. And then, opportunities during an MA visit, a lab visit, on a phone call, you could offer it. What we noticed was really helpful was during annual women's wellness exams, just to offer it during the rooming process. It's a very simple thing to do that our staff could really own. And then some more details about the fit pending tag, just to make sure you're following up on things. And then at the bottom is a contraindication. Patients who are high risk should be assessed by a provider. So that's when the standing order does not apply. That's when the provider needs to make their medical decision about how to care for the patient, and in conjunction with the patient, obviously. And then we have the steps. So the first step is to identify the patients. You have the eligible, and then you have the contraindicated, clearly spelled out. And then this was something that came about when we're talking with our medical assistants. We're like, okay, step 2 is discuss the fit test. And that's all we had written. And they said, what should we tell them about that? How should we try to get them to take it? And so these are some talking points that our MAs use to talk to patients about the fit test, about colorectal cancer, comparing fit tests to colonoscopies. Just some really succinct and direct talking points for patients, for medical assistants to speak with patients about the fit test. Screening for contraindications, making sure that people who shouldn't be getting a fit test aren't. Administering the test, that's going to depend on what kind of kits you have and what your clinic policies are. And then we have steps for documenting it, which is really important to follow up, making sure that you have a good system following up on this. As you can see here, check out a front desk. That's why it was important to have front desk in the team. When they see fit test in the chart and they're not carrying a fit test, they said, hey, did you get this? If they didn't, they can go check with the MA and make sure that they're leaving with the fit test. That's why it's helpful to have the full team part of this designing process. And then the authorization. We had a copy of this with the signed, with the medical director signature. It's just important for legal purposes to have this if you're going to have a standing order for medical assistants to order this test. And just some data, we implemented this in Q2. We had grant funding through the American Cancer Society to do some fit testing. And so that's why you see the increase Q1 to Q2. But then you can see it continues to increase as MAs gave these out to patients more often, and it got done more often. So success is obviously more fit tests given to patients. This team approach was really essential to making sure that we were covering all our bases, how we can incorporate front desk into this workflow as they're not explicitly medical staff, giving them the knowledge. What does a fit pending tag mean? Now they know, they're trained on that. And having a standing order gives ownership of care to the whole team. So medical assistants now have the agency and the ability to communicate with patients, talk to them about what a fit test is, what are the benefits of this, rather than just passing off care to the provider. It really allows, and also efficiencies of speed, rather than having provider add this to their list of things to talk about, the medical assistant now owns this and can administer these fit tests to patients. Some of the challenges that we haven't fully understood how to overcome. Number one is maintaining the momentum. When we first implemented this, people loved it. They were doing it a lot. And then it sort of fell into the list of things they have to do. And then one MA started, actually at all of our women wellness exam patients, we can give this pretty easily because they're there for cancer screening anyway. It fits well. And so that increased the amount of fit tests we were giving out. And then it slowed down again as we had MA turnover. So keeping this as a top of mind thing in the clinic requires reminding, checking in, which is difficult to do. Documentation and reminders really depends on your EMR. Our old EMR didn't have a great documentation and reminder feature for fit tests. We've now switched to Athena, and we're figuring out how can we use the tools that are given to us to best document and remind staff to talk to patients. As the medical records, there's a lot of things going on in it. So just figuring out the best way to use your tools. And then a last challenge that we're still struggling with is when we get a positive fit test, we deal largely with uninsured patients. And so the options for colonoscopies are limited. So, we have Denver Health for Denver-based patients. We have Colonoscopy Assist, who offers, I think it's $1,250 for all-inclusive colonoscopy, which is still expensive. So, giving out more fit tests has been great, but the downside is the more fit tests you give out, the more positives you have, and that we're having a hard time making sure that the colonoscopies are done. But overall, standing orders are a great way to allow your staff to work at the top of their skill set, increase efficiencies, and make sure patients are receiving the best possible care in the most efficient way. There's my contact info. Thanks for letting me talk about how we've experienced standing orders in our clinic. Any questions? Check the chat.
So everyone, Andy put a question in the chat to all of you, which are what are issues and challenges you've experienced with stool-based testing at your clinics, and are any of you also using standing orders? So would love to hear in the chat, and people can come off mute to share their experiences as well. But while you're thinking about all of that, a question I have for Ryan is, how do you think these standing orders have impacted your ability to evaluate your stool-based testing and colorectal cancer screening efforts as well? Do you think it's easier to pull data since this workflow is formalized in the way of standing orders? Is that something you've noticed?
Yeah, so, the different EMRs and different systems for tracking these health maintenance items. And so it was really hard in our old EMR Elation. We had a tag system that had to be manually removed that wasn't associated with the health maintenance. And so we're really hoping that with our new EMR, Athena, we're able to track that better. But yeah, it's definitely a challenge. The fit pending tag would sit there for months, years, and there was no indication of when that tag was put up there. And then you would see a fit test in the chart, but the tag wouldn't be removed. On the other hand, having all the staff involved in it, so front desk, if they saw a fit test in the patient's chart, they would remove the fit tag. So it's a collaborative effort, but it's definitely difficult, once you have more hands in the pot to track things, because tags are being added, it makes it tricky. So, there's definitely good and bad for the tracking purposes, I think. And I saw Laura said it's hard to getting back to them is always a challenge. We implemented this in May, and honestly, at this point, with our EMR transition, I can say they're probably not handing out a lot of fit tests in the course of their care, just because they want to get what's done in front of them done and think about the rest later. So getting back to them, once we go back to our QI initiatives and working on colon cancer, we already have the policy written, so that's a great first step, but getting back into the habit of it is definitely important.
And that would be a really great opportunity for the CCSP capacity building funding too. So for Clinica Colorado and other clinics that are already doing something around stool-based testing, that's something we can really help support, is bolstering what you already have as a foundation. So we can chat with you, Ryan, about possibilities with that, but just wanted to remind everyone of that as well. And then there was a question from Lupe that asked, do your fit tests, and I think she means the instructions for the fit kits, are those available in Spanish for your patients?
Yes, definitely. And our medical staff is all bilingual, and so they're able to help explain how to do the fit test, but definitely we give them Spanish instructions on how to do that. It's definitely important, as most of our patients are Spanish speaking. We want to make sure that they're given instructions in their language. A fit test can be kind of a tricky thing. It's stool based. People aren't quite sure how to do it, it's definitely tricky for staff when they get a test back that's been done incorrectly. It's like, oh, this is not how it's supposed to be. But yes, we have English and Spanish instructions for all of our patients.
And are those instructions that you all developed, or were those developed by the testing kit company, or how did you create those Spanish instructions?
I believe they're by the fit test company. They have English and Spanish available.
Great.
Yeah. Yeah, and so I also see getting the patient to bring it back was a comment on there. That's definitely tricky. You know, when we had that tag in the chart fit pending, we would ask the front desk, you know, if you're doing a reminder call for a future visit, just ask them to bring it back. We had explored mailing them back for a bit, and we ran into a lot of issues with the size of the envelope and making sure that it got to us, and, you know, biohazard issues that we never really overcame. So getting to, you know, that once we revisit our fit test standing order in 2022, we're going to revisit mailing options. But yeah, getting it back is definitely a challenge. You can only educate so much, and, you know, do what you can.
And then Linda from Pueblo put a comment in the chat that many times the order is placed, but the patient never picks up the kit, so the order sits in limbo. And then also echoing the challenge around getting patients to return the kit. So Ryan, have you experienced anything with helping get those kits to the patients? Since I know you just said mailing wasn't necessarily the best option.
Yeah, we definitely noticed, you know, so we have in our standing order, it's possible. So if you're on the phone with somebody, hey, do you want a fit test? You can put an order for it. But definitely there's a lot more success with a patient who is there for another reason, for just to get labs drawn, or if they, you know, had a rash or something and they came in to get that assessed. There was a lot more success in getting the fit test to the patient when they were already there, and the MA could just hand it to them, you know, on a visit that wasn't necessarily explicitly a wellness visit or a cancer screening visit. Getting it to patients was a lot easier when they were already there to get it. But yeah, you know, as we explore mailing it back, we'll also explore mailing it to them, which I, you know, in my opinion, probably wouldn't be as successful, because you want to, I'm not sure if this is part of our standing order, but you want to teach it to the patient how to do it and have them teach it back. Like, okay, so how are you going to do this? And so that was a technique we learned somewhere along the way in our quality improvement, which I feel like wouldn't be as impactful if you're mailing it to them. You know, having them describe it back to you is really important. So we'll explore mailing them out, but really when they're there, just giving it to them has worked out pretty well for us.
And I remember that Sunrise, when we were talking to them about their stool-based testing a while back, one strategy they took related to their sustainability planning to increase their rates was making sure those fit kits are available in all the exam rooms. So it's easy and already there to just quickly give to the patient, and don't have to take another 5 minutes or something to leave the room, go to where they're stored in the clinic and bring them back. So just little small things like that can
It's a good tip.
make a difference and improve efficiencies for everyone. So I'm curious what strategies for everyone else, all the other clinics joining as well, are there any additional strategies that we haven't touched on yet that you found to be helpful for stool-based testing at your clinics? If you don't have standing orders, is there another approach in your workflow that you take with registries, and so reaching out to patients ahead of appointments about stool testing and colorectal cancer screening, doing a flu fit strategy or campaign where at the time they're getting a flu shot, also giving fit tests at that time. Poop on demand is something that a while back the South Carolina team joined us to share about how that's worked for them, getting them to complete while they're actually there instead of bringing it home, as well as provider reports of how well they're individually doing on colorectal cancer screening. So Julie, I think you had something you wanted to share, so you're welcome to come off mute or put it in the chat.
Hello. I'm a little disorganized. I've been typing but can't type. What I was going to let everyone know is that we do use fit tests here. And one of our nurses that was here a few months ago, she put in like a return place that's between the outside door of our clinic and the inside door. And they can return their fit tests in a box. And then the nurses check that, or the front desk check it twice a day to make sure that those get mailed out. And they seem to like that better here than bringing it all the way into the front desk to leave it with their information. So it seems we don't have strong numbers, but it seems to have done better just by eyeballing, watching people come in and out.
Yeah, that's a great point, Julie, that patients don't have to come back for another visit or even have an encounter with a clinic staff member to return their kit. So when there's those opportunities too, people might feel more comfortable if they're just driving by the clinic to drop off their test quickly.
Yeah, they're kind of embarrassed. It's just odd. If you make it normal for everybody, it's not a big deal, but it's hard if you're waiting in line for someone to help you at the front desk. So it seems to have made a difference.
And then Victoria mentioned in the chat, we started with the nurse giving a list of tests to Victoria as the case manager, navigator. The nurse gave a list of all the tests she'd given out throughout the week. And then the navigator or case manager would call them on Fridays to remind them to bring them back in. So yeah, sometimes setting up in your workflow a specific day or process, so that's not something you have to focus on throughout the whole week and after every encounter, but carving out some time and someone who's responsible for following up with patients can be a helpful tactic as well. And then building on that, Laura said during our morning huddles, if CRC testing is on the registry, we address this with the providers and nurses as a reminder that so that they'll then bring up fit testing and colorectal cancer screening with the patient. So many different strategies out there. And I think something that's really helpful is getting it formalized in a workflow or a standing order, something that everyone in the clinic can be clear exactly what the process is, and having it actually written out can make it easier to standardize and continue to follow that process. So for CCSP capacity building, just helping work on little things like that can definitely be something that we could help support. And just with these couple $1,000 awards can go towards the actual materials for getting this done or just the staff time it requires, as well as helping you all strategize and bringing in tools from other clinics and other programs that have been successful. So seems like a lot of you are already doing really great work around stool-based testing, and we want to help you get to the next level with that to help get more patients screened. And Linda mentioned in the chat that their monthly crystal reports are due to identify patients that are due for CRC screenings, and that's sent out to their providers as well as their case managers, and their EMR also is able to alert us in care guidelines. So Linda, if you're able to come off mute, I'd love to hear a little bit more about that. Our crystal report, something that's similar to Azara, where it's really helping with that population management tool, or could you share a little bit more about that? And no worries if you're not able to come off mute. So yep, she said it's similar to Azara, but is able to be pulled directly through their EMR. So for federally qualified health centers, they have access to Azara that can really help with that tracking and patient management. And then some EMRs have that ability as well to really help with pulling those reports, status registries, those types of things. So For those that work with CCHN, they could really help with that technical assistance about how best to utilize Azara and some of those tools. And then for others with other EMRs, we might be able to help support through this work with CCSP, getting you connected with some resources for using those tracking tools as well that are available to you. We have just a couple minutes left. I know we're approaching the top of the hour, so I'm going to stop for one more moment and see if anyone wants to come off mute to share any other tactics, but I think this is really great food for thought as you all are thinking about what you are doing for stool-based testing and those opportunities for capacity building if this is an area you're interested in focusing on. So I'm going to stop right here and see if anyone else has any other best practices or barriers they want to share. Right. So I will go ahead and in the follow-up share a copy of Clinica Colorado's standing order. And Ryan, if you wouldn't mind sending me your slides, I can also share a copy of those as well. And we recorded this call as well. So we'll send out that and all of the follow-up notes from all the announcements we talked about earlier. But I want to give a huge thank you to Ryan for taking the time to join us today and share about the great work happening at Clinica Colorado. They've been a great partner of CCSP and really being able to use creative strategies to help serve their mostly uninsured patient population. So thank you to Ryan and thank you to everyone else who shared about experience as well. And happy December holiday season. We'll see you in 2022. Thank you all, everyone. Bye-bye.